All right, thank you very much for staying with us. This is still Good Morning Nigeria on the network service of the NTA. Just before we bring in our guests for our conversation on diagnosis and treatment of typhoid fever, let's take this background report put together by Ibrahim Bello Gunda.
Typhoid fever is caused by a bacteria known as Salmonella, and a particular species of Salmonella known as Salmonella typhi. It is from that name that we have typhoid fever. It is an infection that leads to very high fever that could also lead to chills, muscle aches, nausea, vomiting, and in very extreme cases, it could lead to mental confusion, where a person becomes confused, delirious, and can even become psychotic.
Ingestion of contaminated food and water. And if there's anything commonplace in Nigeria, it is the consumption of contaminated water and food. Commonplace. And if you go further in the epidemiology of the disease in country, you will find out that typhoid fever is a lot more preponderant in major cities with slums like Lagos, Kano, Abuja, Port Harcourt. This is the right place for ingestion of contaminated food. Of course, it happens in the hinterland and in the rural places where we have poor sanitation and hygiene.
The prevalence of typhoid fever from the study is around 20.9%. And I want to clear it to us that the environment, our personal hygiene, will enable us to continue to be exposed to typhoid fever. I want to also clear that it's not only Salmonella typhi, we also have other strains that we call them paratype A, B, C.
Those were excerpts from our first conversation on diagnosis and treatment of typhoid fever, compiled by Ibrahim Bello Gunda. Now time to introduce our guest, of course, the same guest we had last week, just so we can, continue this conversation and sustain the tempo. We have with us here Dr. Isaac Akuma Abuja, a public health specialist. Many thanks for joining us, Doctor.
Good morning. I'm glad to be here.
Welcome. Also here is Dr. Kashmir Ifeanyi, the 15th National President, Association of Medical Laboratory Scientists of Nigeria. He is also a fellow West Africa Postgraduate College of Medical Laboratory Science and an infectious disease expert. Many thanks for joining us, sir.
Good morning, and good morning, viewers. It's a pleasure to be here.
All right. We have also been joined here in the studio by Dr. Ganiu Jamiu, Chief Consultant Epidemiologist at the Federal Ministry of Health and Social Welfare. It's a pleasure to welcome you to Good Morning Nigeria.
Thank you. Good morning. Thank you for having me.
All right. Welcome, gentlemen. Everybody is in the studio today, so that makes for a more interesting conversation, I guess. But let me begin with Dr. Abuja. In spite of decades of campaigns, why does typhoid fever remain a public health concern at this level?
Well, that's a very easy question to answer, because the causes are still there. Causes as the organism, concerning the organism is still there. Causes of the disease, how it occurs is still the same. The consumption of contaminated food and water is still a practice that we are engaged in. Majority of the Nigerian population still consume foods that are not properly prepared, hygienically prepared. I will explain more on that. The water we drink, like it was explained last week, that typhoid fever is caused by Salmonella typhi, and it gets into the body through the water, contaminated water, and food that we ingest into our bodies. The sources of our water still remains a major public health problem. Majority of Nigerians still don't use or consume or drink potable water, safe water. We rely on any source of water that we can find. And unfortunately, even the so-called pure water, in some cases, that we are drinking is not pure. Unfortunately, that shouldn't be, but it happens. So we still have to look first at the organism. Salmonella typhi is still there as a bacteria, but let me explain even something that is not known to a lot of people. Salmonella as an organism is a part of the flora of our digestive system. If you open my stomach up, take the intestine and open it up and take a sample of whatever you find inside there and analyze it under the microscope, you would find salmonella there. So it is not just the presence of salmonella in the system that is the problem. It is when the quantity is so high. That's why we measure it by titer, that it becomes a problem. And it is also true that a lot of the times the food that we ingest are not properly prepared, are not properly washed, are not properly cooked. And the people who handle the food too, many times, don't have good personal hygiene practices. You see somebody with dirty hands, your cook, your house help, or even yourself, your wife in the house. If she doesn't keep herself clean, and she doesn't practice personal hygiene, and from there does not cook food that is safe. So also that means also that they don't, she or he does not practice food safety, food hygiene. The problem will continue to exist. We will need to change our attitude and change the way we prepare our foods. Every time NAFDAC goes out to say, don't do this, don't do this, people look at NAFDAC as an enemy, which is very unfortunate. They are doing it for our own good.
You spoke about Salmonella typhi being a part of the normal flora of the body, and it is the increase. Is it possible for your immunity to fight the increase? Is it also possible for it to multiply on its own without necessarily ingesting more Salmonella typhi?
Yes, it is possible, but it is not. It will be very rare for the one that is in your system. If you are not ingesting more, the little that is there, if it continues to remain very little, it will not cause you harm. But as long as you are encouraging the growth of the bacteria, the multiplication of the bacteria, it will take over.
Can immunity fight it in any way?
What do you mean by immunity? You mean that the body develops immunity to a point where it defends itself against the bacteria?
Yes.
No, that's not the way to go. That's not the way to go. The level of immunity that is there already is what is keeping the little quantity in the body from affecting you. So, if in a way you can say yes to your question, because if you were not immune to it, by normal understanding, the little that is there can cause you harm. But that is not the issue. The issue is, does the little that is there in your body cause infection? It is the infection that is the problem. And it causes infection when the quantity of the bacteria has grown beyond the normal level.
All right, many thanks, Dr. Iboja. Let's get to Dr. Ifeanyi now. Listening to Dr. Iboja, and of course, with the conditions that we have in the country, I mean, lack of potable water, That's the case in many communities. I mean, personal hygiene is a big issue for so many people. We do not have wash facilities, you know, in certain places, of course. So the issue will now be, how can we deal with this bacteria even when it arises? So we hear that whiteout test is no longer the way to go. What other options are available at the moment?
Thank you very much. I will start driving from where he left off. One of the things I want to put is that the human gut is laden with innumerable microbiota, meaning different kinds of microorganisms. Of course, like you did say, some can just be mere commensals of flora. But then, Salmonella is a notifiable disease. So, somebody can shed Salmonella. Like you recall the last time we were here, I talked about Typhoid Mary. Typhoid Mary was not ill. She was shedding it in her physics stool. She was passing it out. And because of poor hygienic practices, because she became a foci for the transmission of that infection. So all the people who ate her meals came down with the disease. That's not to say Salmonella had become normal flora or what they call commensals in her system. Not at all. Now, so I move away from that, and I'll create a whole lot of scenarios for us today so we can connect right with what is going on. You asked a question, which was this. Why is it with all the enlightenment it had remained? It will continue to remain with us if we continue to do things the way we had done it hitherto. Both in the hospitals, in terms of its diagnosis, our way and manner we go about what we eat and drink. If we continue with that, we do same things, it will not just remain, it will continue to escalate. I tell you, the truth is this: because cholera is high-fallating, that is why Dr. Gani's people, very soon they will say there's cholera outbreak. I tell you, the endemicity of typhoid fever in Nigeria is more worrying than the episodic outbreaks of cholera that we mobilize enormous resources to contain. Because, of course, cholera kills rapidly than Salmonella, perhaps that. But the point is that I've been to other parts of the world, and Salmonellosis, permit me to move from typhoid fever to Salmonellosis, is a notifiable disease. Whether you find it in a poultry farm, in a piggery, in a goatery, among cattle heads, amongst their offals, it's a notifiable disease. And so, what is it that we're not doing right here? We literally live with animals in our homes. There are several things we eat. One of the things that will predispose you to salmonellosis or typhoid fever is consumption of food that is subject to manipulation without cooking. It can come in the way of the various things we drink here, which is part of our culture, or in the form of salads. Because after the manipulation, you don't subject it to any form of heat temperature that can kill the bacteria. Now, we'll move closer to what is the area of interest for me. The area of interest for me is the diagnosis. We are not doing the diagnosis right in Nigeria. Why? Last time I spoke about you going under the tree to be tested for typhoid. I spoke about you walking into a pharmacy where you are just supposed to buy drugs and walk away, and they are running full-fledged testing. I spoke about you walking into a patent medicine shop manned by a semi-illiterate, and he is taking your specimen that he's doing typhoid test for you. So far, the diagnosis keep coming from this kind of ramshackle places and from quacks and charlatans. We will not be able to have it right. We will either be exaggerating the disease or underreporting same. The two can happen because of where we go to seek or source testing. And so, I made a cliche, and I'm going to say it here. The probability that your diagnosis will be wrong is equal to 1 when that test is performed by a non-medical laboratory scientist. The probability that your diagnosis for typhoid and any other disease for that matter will be equal to 1 when that testing is performed by a non-medical laboratory scientist.
Do we have adequate?
We have enough, but they are even underutilized. They are underemployed. They are poorly remunerated. Yesterday, I watched my friend Professor Bala happen on why the Nigerian Medical Association will down tools in 11 days' time. And I laugh. If doctors, I have 2 of them with me here, who are several times more remunerated than me, are going to down tool in 10 days' time from today, you can now know the plight of medical laboratory scientists who face the war. They are in the war front with all manner of pathogens.
No, but
let's come back to the discussion. You asked something about wider testing. Do we have a better platform for testing of typhoid and salmonellosis in Nigeria? He's from Federal Ministry of Health. The answer is a yes or no. Now, one of the places I've been to, by the grace of God, is to a national center for salmonellosis set up by World Health Organization in Institute Pasteur. And so what do? Anywhere from that country where you claim you have isolated salmonella of any type, you are going to courier that specimen to that national center for confirmation. We do not have anything of that nature in Nigeria. We have the National Center for Disease Control, but this system is not in place, particularly for salmonellosis. So countries who had brought the disease burden down had to do different things differently. I tell you another story because I started with creating scenarios. Sometime I did a study in FCT here on salmonellosis. And I included in that study with my team, I'm the principal investigator, we included in that study 2 tertiary hospitals, I don't want to mention their name, big hospitals in FCT, 2 tertiary hospitals, 2 district hospitals, I wouldn't also mention them, and 1 primary health care center. And we aggregated all we call salmonella in Nigeria. I had just about 109 isolates. And I moved it to that National Center for Salmonella. I will shock you that of these 9, when we resuscitated, or 109, when we resuscitated, or only 9 were salmonella.
What were the others?
Any other bacteria, but not salmonella.
So it's not about quacks. It's not about under the tree. Even the well-established.
You see why I answered you. I said, do we have a robust platform for the diagnosis? And I said yes or no. Now, the yes is that there's a semblance of effort being made. But it is not enough. It is weak. The testing infrastructure, the resources are not there. And if we are going to make this a matter of concern, we must speak to those. But we must also speak to the capacity of the human resources. But to your wider before I leave off. Wider is a screening test, old as the disease itself. However, the problem is not only the wider. Last time I told you that there's a kit that is sold 4,000 and there's one that is sold 40,000. That tells you that the 2 of them are not what? The same. Meaning that plenty of the substandard wider reagents are in country. None of them has MLSL validation to date. Now, when you even do this testing, what everybody does is a slide agglutination. A slide agglutination is a mere screening test to suggest to you you need to do another type of that wider test. And I can tell you 99.99% of the time, none of those who do those wider tests get to do that second one, which the slide has indicated.
But Dr.
And like when he spoke through the Zoom platform last time, he talked about a one-off testing. Correct. What makes wider significant is a 2 to 3-fold theta rise. So most people do not understand what I just said now. 2 to 3-fold theta rise. So if I take a wider test, or if you take a wider test from somebody who has gotten the proper training to do it, and he does a slide testing, and the slide comes out showing agglutination, He needs to determine the titer. And I can tell you, 95% of the people who jostle with this thing do not know how to determine.
But just one last question before we get to Dr. Ganiyu. You said you did this research,
yes.
109 isolates,
yes.
and that when you did the final testing, you got just 9
yes.
that were salmonella.
Yes.
Does that say that it's not a serious problem in Nigeria?
It's a serious problem.
So how come out of the 109?
That's why I talked about if we continue the way we're doing it, you may be either under-reporting or over-reporting. Now, what really happened? Most of the places I collected this isolate do not have a typing sera. Typing sera is classical in the identification of salmonellosis beyond your cultural techniques. I'm speaking technical words now. But the point is that these things are not available. If you take a tour of our facilities today, I want to see your panel for typing salmonella, from which you will say, oh, I have isolated it, whether from blood or from the stool. So we need to speak to the challenge we have. These things, of course, like I said last time, are costly. But I expect that government institutions, tertiary health institutions in Nigeria, should have them. Or we will begin to put a laboratory testing network for it that cascades up presumptive isolates to centers like the National Center for Disease Control.
All right. So, Dr. Ifeanyi, for you, it is infrastructure deficit.
And with a laboratory system.
All right. Now, Dr. Jamiu, from an epidemiological standpoint, what are the current national trends in typhoid outbreaks as we speak today, and what are areas are most affected?
Well, I will say the last time I spoke, I don't think we have a national survey that actually gave a true picture of the prevalence in the country. What we have is studies from different zones, from teaching hospitals and so on. I made mention of a systematic review that was conducted in Abuja, and I said the prevalence was around 20.9%. We had another study in Abuja, Zaria, 14-point-something%. So it varies. And there was one in Nasarawa. That was, it said typhoid is common among under 10 years old. One thing I just want to say is that we need to understand the epidemiology of typhoid. Whether we like it or not, we're in an area whereby typhoid is endemic because of the prevailing factors, issue of hygiene, personal and environmental hygiene. However, there are what we call host factors. We have what we call acute carriers, those ones that when they get infected, they show clinical signs. We have subclinical presentation. People may have typhoid, but they are not really manifesting clinically. Then we have what we call convalescent carriers. Those ones that had typhoid, they are just recovering from it. Why I'm mentioning all these things, people, is that somebody can recover and still be shedding and still be transmitting typhoid. Then we have what we call chronic carriers. And these are people that they are not manifesting at all, but they continue to shed this bacteria. And that is why, as you made mention at the earlier, when you were asking the first speaker, it will continue because of these factors I just mentioned. And for instance, if somebody happens to be a chronic carrier and is a food vendor, do you know what that one means? He's not showing symptoms, not showing signs and symptoms, but the person will continue to shed it because of poor personal and environmental.
Like typhoid Mary.
Exactly. That one.
But what manner of surveillance systems does Nigeria have currently to detect typhoid?
Okay, I want to say that typhoid happens to be one of the priority diseases. Unfortunately, because the outbreak is not so visible. You get, it's not so visible. That is why you cannot rapidly respond to it. And one thing that makes issue of typhoid become a complicated thing is the fact that one, when somebody has infection, there's what you call self-medication. Some people just go to seek for help. They go to the counter and just buy antibiotics. So the issue of antibiotics still worship is still an issue. In some countries, like Europe is mentioning, you can't just go on the counter and buy antibiotics. But that is the issue in Nigeria. Then another thing mentioned, access to good laboratory services is another issue. because some cannot even afford it. And let me also tell you, for instance, in the diagnosis of typhoid, he has mentioned WIDA. A WIDA can still give an indication, but it has to be done by a qualified person. And one thing about WIDA is I made mention that one WIDA cannot, because we are in an endemic zone. People have, in one way, naturally been exposed to typhoid.
So you have to
Therefore, when you do a titer, the antibody will show. This is how we read whatever. First, let's say, it's even fourfold. For instance, when you do first WIDA, and it's showing 1/40, there are two antigens, somatic and flagellar. If they show 140, after like 7 to 10 days, you'll repeat, and the WIDA is about fourfold increase. Is an indication that that person is
Okay.
That's how they interpret it. Then I want to talk about blood tests. You know, we're in a setting whereby you cannot easily do blood culture, because by that the person is presenting. Because I made mention the incubation period of typhoid is 1 to 3 weeks. So blood culture, you can only get the sensitivity within like 6 days, 7 days. But people will not come by then, paracetamol sort of thing they will have used. So by the time you even do whatever blood culture, you're not going to get accurate result because of the antibiotic usage. So those are
Thank you, Dr. Jamil. You know, listening to the doctors, speak about typhoid fever and how serious it is, I'm wondering why many of us are still alive. Because, I mean, the prevailing factors, we live with it every day. From what you've said, a lot of people are carriers, like Dr. Jamil has said. Like a lot of Nigerians will say, is it possible that this typhoid doesn't kill a black person? Tell us, if some of all these things that Nigerians are taking by the roadside, paracetamol and all of that, what is it actually doing to this salmonella? Is it mutating it? Is it, I don't know, is it that in the near future we're going to see something worse than, this typhoid fever that we're dealing with at the moment? What is the repercussion of, doing paracetamol, doing antibiotics, and, probably going to prayer houses? Because, I'm just thinking about all of this. And then tell us, what is the correlation between seasonal weather patterns and spikes in typhoid cases?
Okay. Let me start with your first point. The diagnosis or so-called diagnosis of typhoid fever at the moment is exaggerated. That's the point we are making. There are lots of diagnoses or there are lots of treatments that are going on or suspicions that are not typhoid fever. So, last week when we discussed, I mentioned the fact that nearly everybody now, that has fever or not, or suspect that he or she has malaria and is sent to the lab to do a test, they come back and say, I have typhoid and malaria. That's for those that go to the lab. There are many who have not even gone to the lab, they have not done any tests. I don't know who confirms to them that they have typhoid and malaria.
Experience.
Have you noticed that anybody that talks to you, even on the phone, that has malaria now, they don't say I have malaria. They say I have typhoid and malaria. My first question is, how do you know you have typhoid and malaria? In many cases, they have not even done any tests. In some cases, for those that have done tests, the tests are not properly done, like doctor has already mentioned. And that is why I brought in the issue of NAFDAC. Because NAFDAC is the one that is responsible for the for the reagents that we use. And Doctor mentioned earlier that there are lots of reagents that are not standard. And that's why I don't work for NAFDAC, but I'm defending it. When they say, this is not good, don't use this, people look at them as enemies. But they're doing it for your own good. You bring in a reagent that doesn't have all the components, the ingredients that it should have. And this is the reason why, when he talked, he said there are some that cost 40 naira, and the others that cost 40,000 naira. The same reagent. I'm just quoting figure. Why? Because there are some that are substandard. There are some that are real, and there are others that are not. But let's come back again to the real issue. The issue is not, okay, I've mentioned overdiagnosing. either by personal perception, even by those who are not health people, who have fever and they say I have typhoid and malaria, or by belief. There are people now who believe that when you have fever, it's automatically typhoid, which is very wrong. And this way we are begging people to please try and understand. There are many causes of fever in our environment here. Malaria could cause fever. Pneumonia could cause fever. Typhoid could cause fever. And there are many other diseases that could cause fever. So the fact that you have fever does not necessarily mean that it is typhoid. Or the fact that you even have malaria does not mean that the malaria is also in combination with typhoid. My real worry about this is the fact that, one, it is misleading, and like you were mentioning prayer houses, some people now believe that typhoid is so dangerous, and I'm always having typhoid. I have gone to every doctor, and it is not cured, so I had to go for a prayer session, which is wrong. In the first place, those people who say they have gone for treatment, they have not gone for proper treatment. Those people who have gone to the lab, doctor has already mentioned, some of the tests are not properly done. So let's start from there. The real understanding of the situation is important here. The real understanding is the fact that we are exaggerating our perception of typhoid fever. The number of people that are saying they have typhoid is much higher than the real cases of typhoid that we have. That is not to say that we should underestimate the severity, the seriousness, the implication of typhoid fever, the real typhoid fever. Real typhoid fever can kill you, and it does kill, and it's very dangerous. The fever can go very high. The malaria itself, the parasite, the bacteria itself, can eat up your intestine and perforate it to a point where your fever will increase, you will develop septicemia, and you can die from there, or surgery will be required to rectify the situation.
All right. Thank you very much, Dr. Abuja. Dr. Ifeanyi, you've attacked or you have questioned the integrity of the Whiteout test. What are the more reliable options that we have, and how do we get on the pathway of retiring the Whiteout test?
The way the country is today, I'm not an advocate of retire and remove the Whiteout test. I am rather an advocate that the persons performing the test should get the appropriate training and have the right tools to perform it correctly. We are a resource-limited country, and because we are resource-limited, some of these classical testing protocol will still help us. Now let's discuss. I will borrow from what Dr. Ganiu said. He painted a proper picture of the presentation, the pathophysiology and the clinical features of typhoid. Within the first 1 week, if you present in a normal facility with normal resources, blood culture, that means you have not taken XYZ antibiotic. I don't want to mention the name of any particular one. They are likely to recover it from a blood culture if well done, if they have the facility to do it. And to do it in a tertiary hospital that is very close to you here may not be less than 40,000. Do you understand? Between 30 and 40,000. So that's blood culture. Now, if it goes beyond that to the second week of the disease and you have not started abusing antibiotics, you will begin to share it likely in stool. So if a stool culture is properly done, and for us to do a proper stool culture, you see this flower on the table, if you count the items there, for that proper stool culture to take place, the items you need to do a proper stool culture is several times this. So let's face the fact. Now, so even when you recover it, either in blood or in the stool cultures, you will yet need to do a proper identification. You see, we talked about Salmonella enteritica, Serovar enteritica, all right, typhi. There are several other Salmonellas In fact, it's a full page. Oh, yes.
A full family.
A full family. A genus is a full page. Now, within the TYPHOID, you have the paratyphoid, and there are several others like that. So, what is the issue, and how do we get it right in testing? The person who must do the test for you, even if it is as rudimentary, as non-specific as it were for wilder, must have the appropriate training. It is not a matter of mixing blood and serum. No, it is not at all. It is way beyond that.
But isn't that what associations like yours should champion?
Good, I'm happy. We are doing that. Like Dr. Ibuja spoke about. What we are saying, we're happy with what NAFDAC is doing, listing drugs, food, and chemicals. But we're saying that if you are bringing a diagnostic tool, equipment, reagents, rapid diagnostic test kits, and what have you, which will be deployed to testing humans and animals in Nigeria, that the flagship agency saddled with the responsibility of saying this particular reagent meets the claim of the manufacturer and meets the quality system as prescribed by standards. Are you with me? And therefore give you a validation certificate is the Medical Laboratory Science Council of Nigeria. And the worry is that I said, here is a dumping ground for substandard and fake reagents and diagnostics. And we need to support the Medical Laboratory Science Council of Nigeria to live up to this statutory mandate for which it has capacity in terms of infrastructure and human resources, for which it has proven its mettle during the COVID period when it had to subject WHO approved COVID rapid test kits to validation and found issues. Do you understand what we're saying? So that's where to start getting it right from. Now, you see, the thing about salmonella, generally, and I would like to be speaking to it like that, is this. I'll paint another scenario. When I traveled somewhere to do another work, one Saturday, I was having nice time and I was called back. Come, run to the lab, and I ran to the lab. And they had taken samples from a farm. It is in the state capital, that is in the nation's capital. That is the biggest poultry farm. And what did we find out between that Saturday and Tuesday morning? We found out that the farm had Salmonella gallorum. And over 2 million birds were called in seconds. The chicken you eat everywhere here, who evaluates it? I said when I came back, I did a proposal. Can we start dealing with HACCP? That is hazard analysis and critical control point in our food system. It's necessary. I'm not a food expert. But there's one thing we must introduce. What does it do? If I am rearing chicken, from my poultry to the table, where are the hazard points? What controls can we put in place? If I am making kunu, from my house to where it lands on the glass where you drink it in the office when the sun is scorching, what are the hazards that are involved? What are the critical control points? We must tackle typhoid fever, salmonellosis in the food system, in the water and sanitation and hygiene. We must also get the infrastructure for diagnosis right for us to really have a thumb and control it effectively. Salmonella may be underreported, may be exaggerated, but is a very serious disease. It kills, not may kill, it kills. Once it gets to the point of intestinal perforation, it is God help you, because they can even finish the surgery of resection and you will still pass on.
Speak to us about bone marrow testing.
Beautiful. Bone marrow testing will become useful when you get to that convalescence or chronic carrier status. Do you understand? So, and like I said last time, don't hazard it too, because it means we're going to drill into your bone and take and aspirate the marrow.
Does that happen in Nigeria? Do we have facilities for that?
Well, you see, there are times you need to do a bone marrow aspirate. Osteomyelitis, people with sickle cell disease, you may need to do them. But I must warn that our capacity as experts in the health industry is yet to mature that it can become commonplace. It's just like saying, can you do kidney plants in General Hospital Ihamufu? Do you understand? But I know that there are a few places in Nigeria now, within even Abuja here or Lagos, where we can say, okay, we're hazarding with kidney transplant.
Thank you, Dr. Ifeanyi. You know, I mean, all of this is you talking about the food chain now. It brings a lot of complications to all of this. I'm just wondering when we're going to get to that point where, I mean, what is on my table is actually healthy. You know.
Do you know how to get to it? This is the first place to get to it. FCT, Public Health Department. Thank God my friend from Public Health is here. With the FCT Public Health Department. Simple test. Create a team that will take sample from everybody who sells food. In FCT. Don't be too ambitious. First, determine that these people are safe to prepare and serve you food. You see now you are intervening in the food system. There is this I saw elsewhere in another country. I don't know whether it's practicable in Nigeria. If you are a food vendor, whether fast food, big restaurant, from periodically, within a week, they come to take samples of what you prepare to serve people for analysis. So it's not rocket science. I've seen it happen. I've been part of that.
What about people who rear their birds and, you know, the feed from that? How do you do that?
I'm happy you brought this issue of bird. There's something you asked, which doctor, maybe because of time, couldn't respond. Let me bring it to fore. You said, is it that this thing is beginning to mutate? Bacteria do not mutate. Viruses mutate. Now, but this is what is happening. I don't know as my body, they do me. He dashes out, he buys antibiotic XYZ without prescription, without that being indicated from a susceptibility test. Because before you give antibiotics, it must be predicated on antimicrobial susceptibility testing. So you just take it, it can be sub-liter, it can be sub-dosing. What have you done? You have exposed that organism, in this case salmonella, to a subclinical dosing. And he says, oh, now, this is what you want to carry come. It's all right, make sure you say me and my day. He will tolerate it. As he tolerates it, it develops resistance. And as it develops that resistance, it can exchange the gene and the properties that had made it resistant with other organisms even within your system, which are not troubling you. And so, when now that particular typhoid variant infects an individual, fresh person, and the drug that you would have used to cure that person will no longer be effective. That is called antimicrobial resistance. And that's why he spoke about antimicrobial stewardship. Now, the challenge we also have, dovetailing into the issues about antimicrobial resistance in salmonellosis, in typhoid fever, is the fact that there's an unbridled use of antibiotics, antimicrobial agents, in livestock production. Oh, you have a poultry, small poultry, you are discharging chloramphenicol, you are discharging oxytetracycline, you are into the water and all that. You are doing same for your goats, you are doing same for your cattle. So in the long run, one ecosystem, you have propelled the development of antimicrobial resistance, and some of these genes are shared. So when that happens, that is why somebody will have typhoid, and the usual drug, which people will prescribe empirically, may be prescribed because they may not do the test. You will find out that the person will not respond to it because that strain is already resistant.
All right, let's. We have some contributions, questions, comments coming in already, so that we take real life scenarios, not just paint some. But from Elisha Joel from Jalingo, he says, "Good morning to you all. You are really doing a good job of this health issue. My question is, why won't malaria typhoid vaccine be given more attention or taken so seriously like polio in Nigeria?" That's from one. And Yusuf Abdul from Zaria says, typhoid diagnoses are mostly done clinically due to proven ineffective diagnostic resources. Unfortunately, quackery has taken over our health space. Obviously, we are therefore just gambling with antibiotics, which in itself is a dangerous trend. that may lead to multi-drug resistant organisms. I think that point has also been made here. And finally, from Ben also, experts in pharmacognosy believe that medicinal plants can cure typhoid fever. What is your submission on this? Perhaps Dr. Jamiu will help later, but do you have some of yours?
All right, some messages we have here. This one is from Nadom Wuyep from Jos. What are the stages of typhoid fever and how does it progress? What are the potential long-term effects of typhoid fever? Are there any specific dietary recommendations during and after typhoid fever? That's Nandom Wuyep. This one says, I'm worried about the treatment of typhoid at primary health centers. Always IV injections are given. Are there no other options? That's coming from Ibrahim in Yola. It says, good morning, highly respected discussant. I've listened to the debate on the inconclusive nature of wide-out tests for diagnosis of typhoid fever. What about stool culture? How reliable is this? This one says, NTA, well done for a good job. Dr. Abuja, you have a fan here. It says, good to see you, and I want to appreciate you for your analysis and the way you handle health-related cases. That's Jackson Dama. Good morning. I've listened to the doctors in the studio. Please, what do you do to eliminate malaria and typhoid to a bare minimum, since the drug dealers and manufacturers are milking the citizens? This is what had made us to resort to roadside medication. Even when you enter a pharmacy and complain, the first question is, have you treated malaria? Or when did you treat malaria last? That's coming from Ikedichi from Abakaliki. All right. I think we just take turns.
You want to respond to some of the questions?
Yes. You see, I want to say, whether we like it or not, Nigeria is an endemic zone for both malaria and typhoid. And there's nothing we can do. The only thing is to develop strategies to reduce the burden as much as possible. First and foremost, we talk about malaria. Nigeria is an always endemic zone. So at the moment, there is a malaria vaccine. It's been piloted in 2 states. It has been introduced.
For you, sir?
I can't remember the second state. We just finished. So they should be patient. We are trying to evaluate to see before it will be rolled out. But whether we still like it or not, environmental factors still play a very big role. The climate change. We are talking about what will continue. For instance, year in, year out, during rainy season now, with contamination of underground water, food surface and so on. Open defecation. Until Nigeria is free from open defecation, we'll continue to have typhoid, cholera and so on. Because, during rainy season, all those feces, they get into everywhere. Are you getting it? Then, secondly, there is a season whereby, according to NIMED, when there is blowing of wind, we had a meeting recently, those feces that during wind period or whatever, they go blown into surfaces, water sources and so on. So these are some of the risk factors. So then in terms of typhoid vaccine, you see, Nigeria is qualified to include typhoid vaccine into their routinization. What are those criteria? Being an endemic zone, and for the fact that we abuse antibiotics. The issue of antimicrobial resistance is an emerging issue at the moment. So I will suggest, people may say, okay, it's not really a big problem, in the sense that when you look at the global burden of typhoid, it's 9 million people get sick from typhoid, and about 160 or so dead. In sub-Saharan Africa, around 7.2, 3.8 for paratyphoid, death is around 130. People may say it's not really an issue. It's South Asian, South America, Southeast Asia, more of those areas. That's why you see that. So how we prepare, because it affects more. All those complications they mentioned affect more of our children under 15. All those perforation and so on. So it has been introduced in countries in Nigeria, that the type of conjugate vaccine, because of the fear of antimicrobial resistance. Initially it was, I don't want to mention, but simple is no longer working. Somebody made mention of IV. You know why they are doing that? Because the first line drug, because of antimicrobial resistance, is not ciprofloxacin is no longer working. So they now use ceftriaxone You get what I'm saying? So these are some of the reason why they will see some people using IV.
You mentioned something that touches me. That's children in all of this.
Yes.
How can they be protected?
In many countries, as I said, is use of, you introduce typhoid vaccine to routine immunization. It's currently being practiced in 3 African countries, Malawi, Liberia, Zimbabwe, because they have to introduce it because of the challenge they had with the body.
Outside the vaccine, there's no other way.
That's the only way we can protect them, because if you look at the issue of the presentation, the way we abuse antibiotics, lack of access to laboratory services and so on, the diagnosis is an issue, and the issue of the fact that you can just get access to antibiotics everywhere. So we are now breeding in more of antimicrobial resistance. So the best way to protect our children is to introduce that vaccine. They may say, well, it's not really a priority as well, but I think many countries, that's what they do. And the one thing about typhoid conjugate vaccine is that it's only giving 1 dose, 6 months and above. And it can protect, the protection is around 79–85%, and it can last for up to 10 to 15 years. So that's what many countries have succeeded in introducing to their routine immunization program. I think.
So can medicinal plants cure typhoid fever like someone else?
Well, you know why? Not that some of these antibiotics, majority of these antibiotics are gotten through medicinal plants. But however, has it been subjected to clinical trials? What is the dosage?
What are the limitations for us in Nigeria to do some of these clinical trials? I mean,
have we
with
tried?
what we have.
No, there are some clinical trials going on in the country, but it depends on the priority. Like some antibiotics, some things, for instance, the PVAC being introduced by the Honorable Minister of Health, they are currently partner with some stakeholders. Even yesterday, it was mentioned on TV how they are making effort to partner on carrying out some clinical trials. So it's not that it's not going, but it's just that maybe the publicity is not much. And it now depends on our priority and what we want, but it's ongoing.
Dr. Goja, you want to respond to some of the questions?
Yeah, let me respond to some of the questions that the concerns that people have. Dr. Ifeanyi mentioned the constraints, the financial constraints that people have. And I think that needs to be emphasized. Antibiotics are not cheap. No drug generally is cheap. They are expensive. And it is worrisome for somebody who doesn't need something to buy that thing which he or she does not need. That money could be used for something else. I already said that a lot of the cases of typhoid that people are saying I have typhoid are not typhoid in the first place. But people are taking treatment for them, which is wrong. And we should be concerned about this. If you go and you are taking antibiotics, which you don't need, you are doing 2 things. 1, you are causing drug resistance, which we have all talked about here. 2, you are weakening your financial strength. That money could be used for something else. Perhaps even the fever that you said you have, which could be treated very easily if it is malaria. With maybe 2,000–3,000 naira it is treated. Now you are adding 5,000, 7,000, 10,000 naira to it to buy antibiotic. That money could have been used to buy food. That money could have been used to buy safe water for those who are collecting water anyhow. You could use that money to buy bottled water. Let me still repeat what we did, what I said last week. Let people take time and be sure of what the problem is before treating. We've already talked about this self-medication, which is a problem. Why would anybody, just because you have fever, you run to the pharmacy and you demand? Some people don't even ask questions. They demand what they want based on what they think they have. It's a big concern.
They know their body.
No, there's no such thing.
All right.
That's what they
We'll
say.
just pause here for a break so that the conversation will continue after this break. Please don't go away. All right, many thanks for staying with us. This is still Good Morning Nigeria on the network service of the NTA. If you've just joined us, We've been talking about diagnosis, treatment, and all whatnot, about typhoid fever. I think we have some more reactions here. Perhaps we set off this stage with that.
Yes, I have this very interesting one before you go on. This one says food handlers now grow nails, wear artificial nails, do makeup and all that, wear ornaments to prepare food. So, I mean, what's the solution? This is coming from Iyabo Ayodele from Usi Ekiti. Many thanks. This says, please, you people should address issues of self-medication, which is common with chemists. That's another dimension of pharmacy now. Amen, Victor, that's from Benue. This says this topic, diagnosis and treatment of typhoid fever, is a great one that has been underestimated because of how it's been handled by quackery. I'm glad about this enlightenment program. Thank you very much. That's coming from MLS. I think that's your colleague, Daniel Adiozo from Jalingo, Taraba State.
All right, and this one reads, Good morning, Nigeria. I'm Mohammed from Okene in Kogi. I think we need to get it right this time around. We need to stop self-medication and do proper diagnosis before treatment. And then another asks, does typhoid make one's veins to turn green? Well, the doctors will respond. And finally, good morning all. Thank you so much for this very educative lecture. May Almighty God reward you. Amen. Is it true that typhoid can be diagnosed through blood? That's from Aja Abiri from Edo State.
All right. Dr. Ifeanyi, you want to pick up?
Plenty to deal with. Now, if she had listened to us earlier on, we had talked about the various specimens and timing for each of those tests. Of course, typhoid can be diagnosed using blood specimen. So the answer to that is straight. But let me speak to you.
And blood turning green. What's that about?
Well, you see, the person needs to go to the hospital for a holistic evaluation. I wouldn't want to say it is this or that. But there's something we need to speak to. These two physicians that are with us here this morning can recollect that as students they were taught what was called pyrexia of unknown origin. That is an omnibus acronym. We call it PUO. To warehouse all manner of fibroid illness. So you do a differential to establish what is causing it. Today, as we blame quacks, plenty quacks everywhere, agreed. Today, those of us who are the proper healthcare professionals, we also need to know our onions. It's important. Within the FCT here, I've lived here for some time. You take you go before a physician, like what is written in the holy books, while you are yet speaking. While you are yet speaking, the physician gives you a prescription. Full with all manner of drugs, including antibiotics. Then he, not after thought anyway, as an ancillary to the prescription, he now makes laboratory requests. I'm not talking of private hospitals. No. So we need to also speak to ourselves as practitioners to do the right thing. Because if, like Dr. Abuja had said repeatedly here this morning, if you don't have the diagnosis, you are gambling and you are jeopardizing life. So how do we get the diagnosis? It starts clinical presentation, provisional diagnosis, and the laboratory workup report will now help confirm that diagnosis. That is the right way. Now, we are all talking about antibiotics. The proper protocol for antimicrobial stewardship is that if I'm going to give you a prescription for antibiotics, if a physician is going to give you that, it must be predicated on an antimicrobial susceptibility test. Agreed, in life-threatening condition, he might rely on empirical, and that empirical derives from data built over time. So one of the things we must return to as practitioners is to insist first with ourselves that for me to write this antibiotics, it has to be based on an antimicrobial result. That's the way to go. That is properly done, not cooked up. Now I come to the issue of, you talked about medicinal plants. we have a rich biodiversity. And there's no gainsaying the fact that we have things here, and I repeat here in Nigeria, that if properly researched and developed, can help us reduce the cost, because all these antibiotics, 95% of them or more are imported. I give you an example. There's an institute in Abuja here called TYPHOID. I remember very well that there's a plant they call malaria number 1. It is common in parts of Adamawa and my village. In parts of Adamawa, people use the leaf of that plant to wrap what they are cooking, and they don't have malaria often. It was fully researched in TYPHOID. Where is malaria number 1? It talked the leaves before Artemata. Today, Artemata has become mainstay. Something is really wrong with us. Now, that same institute fully researched on the use of bitter leaf to manage diabetes mellitus. Patented it. I hope you know it has been sold. So it is now prepared abroad and imported. So do we have plants that may be efficacious against salmonella? Plenty. If you go to research institutes, if you go to the universities, particularly in some faculties of veterinary medicine, you will see plenty clean research work supporting the efficacy of some medicinal plants. I think we also need to look in that direction. And not just for the research purposes. Can we patent it? Can we make it proprietary? Can it become available on the counter? These are things we can do as a nation to help ourselves. So for typhoid, and like every other disease, it's important that you have to be sure of what is wrong with you. You see, we created some of this problem ourselves. I led a struggle, mark my word, to Federal Ministry of Health then, and insisted that these people promoting ACTS in Nigeria, because that time said, your body they do you somehow, make you take ACTS. We insisted, myself and my colleagues, I wasn't president then, and he said, no, you must redo this advert to say, if your body they do you somehow, make you take test if it be malaria. That if you watch, that is the new advert. It was a struggle to get that happen. Otherwise, the initial way was, if your body do somehow, take it. No. So there are things we as a people had systematically done wrong. So if it will require a systematic redemption to get it right. So that's the thing about the Nigerian health system. We are richly endowed with human resources. That is why they come pinch that here, pack our doctors, pack our nurses, pack medical lab scientists, and go abroad. But the limitation is that do we have the enabling environment? Do we have the resources, the wherewithal to work? Can we come to work proud and go home fulfilled?
Many things.
Or we are working and I'm thinking of, how do I buy fuel of 20 liters to go home? Doctor, and that is why he will quickly write you the prescription and the test you can go. He is going to look for how to get the 20,000. So it's important that those of us have decided to stay here to build Nigeria because we believe in this country. Government must do the needful. Deal with the demands of NMA. Deal with the demands of the healthcare profession. If you are reviewing the CONHES structure, review it across board. Let everybody be happy because it is a system. A chain is as strong as its weakest link. The challenge in the Nigerian health system is weak medical laboratory system. A chain is as strong as its weakest point. So the weakest point in the health system remains the medical laboratory service. We must comply with the Maputo Protocol of 2008 of strengthening and expanding laboratory services. That is the key to mitigating not just typhoid fever, but all other infectious and even non-communicable diseases that are ravaging.
And of course, we'll have a healthy nation. Many thanks, Dr. Ifeanyi. Well said. We have some more messages. I would like to take them because this is health related. This one says, "Good morning, Nigeria. Please, what should we do in practical terms when we feel feverish as a poor Nigerian?" Please take note. That's coming from Abdul Kadir from Lokoja. This one says, "Morning to all. Thank you for the job well done. Please, what are the signs to look out for, and what can we eat to avoid typhoid fever. That's Rahila Peter from Jos. So let's get one of the presenters and doctors. Advise from Lokaja. Please, how can government come in for its citizens to get lab tests at times? At times is far above our income. All right. You have some more messages?
No, I don't have.
Okay.
Maybe Dr. John.
To issue of greenish vein or whatever. If you see lights, people that are light in complexion, you see the vein looking greenish. There is nothing, unless if there is somebody's having painful vein, whatever. When we talk of phlebitis, and that person should just go to the hospital. But if it's not just a normal whatever, not painful, not showing any abnormality, I don't think there's anything to do with that. Then I want to respond to
the poor Nigerian.
The poor Nigerian. Well, what we do, you know, at the moment, I agree with you. You know, there is what's called Basic Health Provision Fund, and that take care of the vulnerable and these how to reach people. So I think there are provisions for that. That person can go to primary care, the end of the primary care centers. You know why? Because there are in some majority of the primary care centers there are free drugs for treating malaria. So that person can go there. And,
what are your recommendations? I mean, to deal with all of this as we begin to round up this conversation.
Okay.
What do you think government can do about all of this?
Well, as I've said earlier, I'm in support of vaccine because looking at the criteria for introduction of type of vaccine, being endemic, the issue of antibiotic abuse is a weak health system. It's not only the lab, the weak health system and so on. However, at least let's take care of those age group that are more vulnerable to that. That is under 15 years old. They are the ones that are prone to perforation and so on. So if we can introduce that, it may go a long way in helping that. Then regulation. I don't want to call appropriate agency. We need to stop this idea of pharmacy, patent medicine, so claiming to be doctors, treating people, having offices without diagnosis and treating. We need to try to ensure and be more strict on our regulations. That should be proper regulation to stop all this. People should go to health facilities. So I will advise that.
Thank you very much. Dr. Abuja, seeing the role of poor sanitation in transmission of typhoid, what's your assessment of the relationship between sanitation authorities and health authorities? And what should it be like?
Well, in the first place, we need more sanitary officers than we have now. I recall when I was a small boy, we used to have them with very fine uniform. And if you go to the local villages and their markets, on market days, we used to admire them with their khaki shorts and looking very nice white shirt, looking very smart. We admired them in those days.
And consider them a lot of trouble.
Yeah, and they go to where they're cooking food in the market, and they look at the pot and say, this meat is black. It must have been a dead goat that you cook. And those days they had authority to take the meat away and throw it away.
Were they really throwing it away?
I don't know. I'm telling you what used to happen. We don't have sanitary officers now. There are a few, and there are a few institutions that are training them. I will advise that we have more of them. I will advise, based on the questions that we've received from listeners, that we really insist on us looking after ourselves. We are talking of environment. There are many things we can do to prevent diseases. Prevention is the way to go, especially when you don't have the money. If you must boil your water, how long does it take to boil water? Not much. The money you use to buy kerosene, if you are using kerosene, which is very expensive these days, or gas, or firewood, whatever you use to cook, compared to the money you will use to treat yourself if you become sick, are not even comparable. They are small. So why don't you take the route of prevention? If you must need to boil water, especially for those families who are going to prayer houses because every time they go for typhoid fever, their typhoid fever relapses. It doesn't go. It is because their personal hygiene and food hygiene has not changed. Cook your food properly. Wash whatever you're not going to cook before you eat.
Wash
it
hands.
properly. Wash your hand. Somebody talked about long fingernails. I spoke about this last week, and I want to repeat it again. Don't have anybody in your house, especially house helps, keeping these long nails. If they cannot cut them, fire them. You don't need them. Your nails should be as manicured as mine. This is how it should go. And so when you wash your hands, there are nothing hiding somewhere here.
I was hoping the camera would zoom in on that manicured finger.
Okay,
Just
so don't have those ladies who, by the way, the beginning of these long nails are those who said, I can afford it. I don't need to cook. I don't need to wash dishes. I don't need to wash clothes. My house help will do it. So they put extra nails to prove that they can buy services from other people. That's how it began. But do we all have that strength, financial strength to hire people? And even if you do, you yourself, do you want to keep bacteria, viruses in your system, in your fingers for yourself? Is it desirable? The answer is no. So let us please do everything we can to prevent diseases. That's the key. Do everything you can to prevent diseases. Secondly, before I finish, let us do everything to make sure that when we are treating any disease, not just typhoid, we are sure of what we are treating. It is very important. Dr. Ganiu mentioned it, and I want to repeat it again. Don't treat what you don't know. There are times when somebody is desperate, and you go for a treatment of a suspicion, just to save life. I don't have time to go into this, but they're not common. Make sure what you are treating is known. It's like you heard a noise in the dark in your house at night, and you throw every weapon you have. You shoot, you throw arrow, you throw, you use gun, you use machete without knowing what it is. How about if it is your dog? How about if it is your neighbor? How about if it is even one of the members of your family?
But what if you are treating what a doctor told you about? Maybe you don't have it. I mean, that's also common, misdiagnosis.
That's why
I'm not exempting anybody. In fact, I want to repeat this. Do not give anybody something that they don't need. If you are treating for antibiotics, for example, you're going to use antibiotics. If one antibiotic, the leading one, can do it, why are you adding all the other ones? In the first place, every drug you take has a side effect. So you're increasing your problem. Secondly, why are you taking the money that this person can use to do other things to buy what he or she does not need? So prescribe only what is needed. Do not
Thank you very much.
The financial body.
Thank you, Dr. Abuja. Dr. Ifeanyi, your last words as we round off. Recommendations, what we should do.
He talked about basic health fund from deriving from National Health Act, and I'm happy the current leadership of the Federal Ministry of Health under Honorable Coordinating Minister Professor Ali Pate is doing a lot in that regard. At the time we got to a point, I'm speaking to the poor person who said when he's sick what he will do. At the time we got to what was called minimum package for health, I think that was 2-3 years ago it came out. There's still a challenge in that axis. We have close to 20 to 30,000 primary healthcare centers in Nigeria because there's a target of one primary healthcare center within 3 kilometers square radius. I can tell you less than 10% of them have a semblance of laboratory. I did a program with a sister station where we did a real-time survey of showing how what were called labs and primary healthcare centers looked like. It's an eyesore. And so, this person who is poor, the closest he should go is to a primary healthcare center. And expectedly, deriving from the basic healthcare provision fund, there should be minimum thing. So we're urging government to, when I became president, I spoke with Honorable Coordinating Minister and I said, can we do a volunteer scheme between my association and the National Primary Healthcare Development Center, where we can map primary healthcare centers and see how we support them in the area of building capacity for testing. Nobody is discussing it. We bring this idea, it dies when you mention it, maybe because I don't know. Now, the other thing that is important, the person who says, what will I eat not to have typhoid? Please, typhoid is contamination of food and water. That water is bottled or in sachet does not mean it is safe or is portable for drinking. So if you are able to manage what you eat, what you drink, how you drink them, and the source, you have done a lot of prevention. But when you don't understand, get a laboratory diagnosis.
All right. Thank you very much, Dr. Ifeanyi.
From a qualified.
Yeah, really?
Yes, from a registered and qualified medical laboratory scientist.
All right, many thanks. We'd like to appreciate you, for joining us again this week, Dr. Isaac Akuma Abuja, public health specialist. It was indeed a pleasure to have you. Thank you so much for joining us again today. Of course, Dr. Kashmir Ifeanyi, 15th National President, Association of Medical Laboratory Scientists of Nigeria, Fellow West Africa Postgraduate College of Medical Laboratory Science, and an infectious disease expert. Thank you so much for being our guest. We hope that some of your recommendations have been heard by the appropriate authorities. Well, Dr. Ganiyu Jamiu, Chief Consultant Epidemiologist, Federal Ministry of Health and Social Welfare. Thank you once again, Doctor. And of course, we hope that we have a healthy Nigeria at the end of the day. So that's Good Morning Nigeria this Friday. Thank you so much for being a part of it. I'm Yen Ray John. Leave it locked on the NTA.
And I'm Victor Azu, Senior General Manager.